Okay, well, why don't we go ahead and get started this beautiful Saturday morning in July. Appreciate all of you who are on, taking the time to um, sort of chime in and be part of this AFS third monthly webinar. And today we're addressing issues of dealing with achalasia and other motility disorders with a debate between Santi Horgan and Ken Chang on Heller myotomy versus POEM procedure. I think it's going to be a fascinating discussion between the two of them, both experts in their respective fields. And so I think without further ado, I'll turn it over to Dr. Chang and let him get started with presenting the side in favor of POEM. Ken, take it away.
Thanks, Reg. Good morning, everybody. Hi, Kate. Hi, Santi. So I'm going to share my screen. Okay. Can you all see my screen okay?
Yeah.
All right. So I've been anticipating this day, counting the days for the big match, Heller versus Poem. And I've been thinking about it like getting ready for a fight, and I'm sizing up my opponent, who is arguably quite formidable. Look at those buff arms. Look at the stature. Look at those very focused eyes. Quite a formidable opponent. So I had to kind of, go to my closet and get out my martial arts gear. So in preparation for this fight, I'm actually going to put on my fighting gear here. Santi, just for you. I was a brown belt in Taekwondo, but I even if I come at you with a very different technique, I'm just afraid of what'll happen when you push me to the corner and I'm up against the ropes, and I may be stuck. So I've sought help along the way. I got, I'm not a surgeon, so I had to get into a surgeon's head, and I asked Kevin Revis, how does a surgeon think about this, and so on. So I got some help, but my main help in terms of boxing is my good friend, Manny Pacquiao. So okay. Manny gave me some really good tips on how to, how to get out of those tough corners. So here we go, Santi.
Very nice.
But really, when I think about Heller and Poem, I don't think about them as either or. I really do think about them as Kevin said, arrows in a quiver. That we're looking at doing things better together. We're looking at technologies that in certain scenarios and situations offer some advantage. And I think for me, it's not so much one replacing the other. And in many centers, either is absolutely perfectly fine, but there may be situations where one may have an advantage. So I'm going to focus more on that. But at the end of the day, I feel like any center that is a center of excellence for the esophagus should have access to POEM as well as lap Heller. So first, I will talk about some scientific evidence, but I think it's equally as important to talk about more real world practical considerations when we think about POEM. Now, as far as scientific evidence, we've been arguing for a decade plus on the efficacy of POEM versus Heller, and focusing a lot on the GERD aspect after POEM versus after Heller and Dora or Toupet. So finally, the much needed, much sought after, long awaited prospective randomized trial comparing POEM versus LabHeller was just recently published in the New England Journal of Medicine. And in this seminal paper of 221 patients with achalasia randomized to the two modalities, showed that at 3 months, the patients with clinical success, meaning Eckhart score diminished below 3, was 94% for POEM, 89% for LabHeller, which was not significantly different. And then at 6 months, fairly equal. At 12 months, fairly equal. And out to 2 years, fairly equal. So I think this is a fairly definitive paper saying that POEM and LabHeller are equally effective in clinically resolving or diminishing the patient's dysphagia. Now, if you want to really get into the weeds, they showed that POEM perhaps is more successful, but the advantage difference is 1.4 percent points. So that's quite a small difference, obviously. What about GERD? Or what about serious adverse events? So in this series, again, of 221 patients, the serious adverse events percentage-wise were small. In the POEM group, about 3% SAE. In the Heller group, about 8% SAE. So if we look at the serious complications for POEM, 1 aspiration, 1 closure leak, 1 pneumothorax, nothing terrible. If you look at the LabHeller group, 1 aspiration, there were 3 mucosal perforations. If you perforate the mucosa from the serosal, from the adventitious side, it's essentially a leak. And so 2 of these cases had to undergo a repeat laparoscopic rescue for perforation closure. And 1 patient had a prolonged hospital stay. There were 2 pneumothorax thoraces, prolonged pain requiring hospitalization, 2, and 1 patient had a scarred hiatal stenosis. So these are significant, adverse events, and so this may be something that, in the long run, is something to consider, meaning the rate of esophageal perforations. In the POEM group, there were none. What does Santi have to say about perforation rate for LabHeller? So I looked in the literature, and this is his paper looking at robotic versus laparoscopic myotomy, and the laparoscopic Heller myotomy group had a 16% esophageal perforation rate. So it looks like this is confirmed by my opponent that LabHeller may have a not zero esophageal perforation rate. Getting to GERD, this is something that we talk a lot about. Surgeons talk a lot about GERD as the reason to not do POEM. So here finally we have the outcome from the New England Journal study. This compares at 3 months that both groups had post-procedural GERD. If you look at all grades, 57% had some degree of esophagitis in the POEM group versus 20% in the LabHeller group. At 2 years, it was 12% versus 109%. But if you look at the patients with more clinically significant esophagitis, this would be your LA grade C and D. We see that in both LabHeller and POEM group, the numbers were small, 5-6% CD, LabHeller 3%. And then at 2 years, it was 5% versus 7% in terms of grade CD. So at 2 years, the severe esophagitis really were quite similar between the 2 groups. What about pH study and acid exposure? It was interesting that at 3 months, there was a slight difference. 44% had an abnormal acid exposure after POEM. 33% after Heller. But at 2 years, it was exactly the same, 30% and 30%. So perhaps the GERD issue is not that big of an issue. And if it becomes an issue, fortunately, we have a endoscopic solution. This is the transoral incisionless fundoplication, or TIF. And in our hands, 5% of patients after a POEM may wind up getting a TIF, which again is a transoral procedure which can create a very nice flap valve and salvage the patient's GERD. We've not had any patients who required a laparoscopic rescue for the GERD. Now, on to practical considerations. We talked about some evidence, and there's a lot of literature, but time wouldn't permit that. But I want to talk about some practical considerations. So one practical consideration is obviously the patient's perception. Patients walk in the door, as we all experience, wanting a certain procedure. And so we get a lot of patients walking in the door saying, hey, I don't want surgery, I want that POEM procedure. So I get this all the time. Patients come in and they say, hey, I saw you on YouTube. And this is the YouTube that they're referring to. I'll show you a little snippet of that.
Hi, my name is Dr. Ken Chang.
And so there I am on YouTube explaining the POEM procedure
In patients with type 1, 2
and put in some cool animations
outflow obstruction.
and show them that I'm going to make a tunnel and I'm going to make a small incision, and then I'm going to go down and create this nice little space. I'll take care of any blood vessels, and then I'll cut the muscle. I can switch to a scissor type device and finish the myotomy, come out, put in clips, and done in 3 minutes.
Wound has healed,
so
will
patients
fall out into the stomach and go out the other end without patients noticing. So this
patients
is
say,
the
yeah, can I have that
entire
3-minute
POEM procedure
Can I have that 3-minute POEM
summarized in this
procedure?
animation. Hi, my name.
Other considerations are certain disorders. Maybe you may want to consider the POEM procedure. Spastic disorders are notoriously, difficult to treat, coming from the abdomen. Type 3s that have spasm throughout the esophagus may be harder to reach laparoscopically. Jackhammer esophagus also can have spasm high up in the esophagus, as well as DES. So in these spastic disorders, POEM may have an advantage by coming from the mouth, and where we can do very, very long myotomies, 15, 20 centimeters if necessary, because of our access point. So these are typical patients who have spasm, as you can see here, spasm going all the way up to the arch of the aorta, and trying to get all of those muscles coming from below may be difficult. Practical considerations number 3, redos and altered anatomy. So a redo Heller, a redo POEM, someone who's had Botox ×5, someone who's had pneumatic dilation ×3, all those tissue planes have been distorted and ablated. So we find that POEM rescue can be quite effective. Typically, Hellers are done anteriorly, and by doing the POEM posteriorly, we tend to avoid most of the scar, and we can do it quite efficiently. Patients who've had a Roux-en-Y, gastric bypass, or a sleeve, again, going back in laparoscopically, dissecting a previously treated area may be also more difficult. And so POEM may have an advantage in coming in from a different plane. So this is a surgical, more or less, guiding principle that if some area has been approached, say from the outside, open surgery, you may want to come in from the inside laparoscopically. So this outside versus inside concept is a surgical concept that that I learned from the master Santiago Horgan, who published this paper saying peroral myotomy after gastric bypass, an effective solution for de novo achalasia. And the surgical principle is that POEM offers an advantage over vsHeller because the myotomy is performed within fresh tissue planes and avoids the need to dissect in a previously open hiatus. So right from the mouth of the master, I think he agrees that in redos, we have new fresh tissue planes that we can approach. All right, practical consideration number 4, patient experience. So there are no incisional pain that the patient would experience after a POEM, obviously, and there's a tendency to be able to get back to work sooner in terms of the recovery. The hospital stay may be similar, but the return to work may be faster after a POEM. Okay, and finally, practical consideration number 5, I think POEM is way cooler. It's newer. There's lots of room for innovation, and I'll just show you a couple examples of that. So we recently published in Vito GIE our initial experience with this scissor type knife. And the idea is that, when you get to the tunnel, as surgeons, you guys have scissors and harmonics and all these cool tools, and we don't. And so here is a scissor type device that we have been using in ESD, and it's been great for difficult tunnels where there's tons and tons of blood vessels. This is like a forest of blood vessels, and you can see now we can now use these surgical type scissor type devices to get us through. This is the iKnife, which allows for injection and cutting and coagulation. So we can do very precise myotomy of just the circular fibers. And then when we need to, we switch to the scissor type knife for the more distal myotomy, where we can grab full thickness and coagulate and cut. One of the things that makes us worried when we just use a simple freehand knife is when you cut down into the muscle and you hit a vessel that's deep in the muscle bed, you wind up getting a bleed that you may not be able to stop because it's far out of your field. So these are some of the things that we've been able to play with because of the new technique. This was accepted for ASG this year. Unfortunately, it was a virtual meeting. We call this the navigational pocket technique to minimize post-POEM GERD. And the concept here is that if we do myotomy along the posterior side, we wind up cutting a lot of the sling fibers on the stomach, which are actually quite important as an anti-reflux barrier. So we don't like to cut those sling fibers, but the posterior approach seems to be more ergonomically friendly for POEM. So if we go more to the lesser curve, however, we get much less disruption of those sling fibers and conceivably much less GERD. So we tried to figure out how can we go in the tunnel and know exactly where we are and wind up dead center in the lesser curve. So we figured out a way to do that with this navigational pocket. So we present the case, and here I'm doing the initial injection at the incision site, but then I'm going to create a navigational pocket by injecting all the way down. So I'm making a bunny trail all the way and ending up right at the lesser curve. So this is all injection from the mucosa side to create. So I've essentially created the entire tunnel even before my first incision. Now I'm making the incision. Here's the eye knife going. I'm doing the submucosal dissection. And then here I'm doing the myotomy. And I'm ending up right dead center in that lesser curve and close. So we're finding that a much less GERD with this improved technique. So Santi is all about the future of surgery. Heller's been around for, I don't know, 100 years, Lap Heller maybe for 30 years. And so anyone future oriented will find that poem is a lot cooler and more fun. Now, you know, I looked and actually Santi was at the very beginning of poem. I found this paper, the first US experience published in 2013. So Santi was very early in the game with endoscopic myotomy. So clearly a pioneer. But Santi, you got the wrong name. You called it a team. If you called it poem, you know, it would have made big time. But anyway, so, but what's in the name, right? And then I looked in clinicaltrials.gov and wanted to see who's doing what in poem. And lo and behold, there he is. There it is. UCSD has a clinical trial on poem. And so is that the GI guy at UCSD doing that? So I looked it up and see who's doing poem at UCSD. Oh my goodness, it's Professor Santiago Horgan. He completed the trial recently, enrolling over 100 patients. He must think poem has legs if he's done over 100 cases. All right. There are some practical considerations, though, for Heller. I could just think of two. Maybe there's more. One practical consideration that's real is poem doesn't get reimbursed very well. We don't have a CPT code. So those of you who are interested in getting paid, that is a consideration. We use an unlisted code, and there are a lot of folks, Christy Dunst and others, who are working on getting us a CPT code. So that is a real practical consideration that has resulted in some decreased poems in centers that do both, like the Portland group. Practical consideration number two, if you've got a patient with achalasia and a hiatal hernia, I think that would be a situation where you just go laparoscopically, do the Heller, do the hernia repair, and do the door or toupee. So that's a clear indication for going straight to a laparoscopic approach. So I'm finishing up. Santi, you know, an amazing pioneer. You know, he's going to tell you about cool stuff, robotics. But Santi, you know, how much does all that equipment cost? You know, all you really need is some good hands and an endoscope. So with that, I bow to you, Sifu, and I await for your esteemed honorable lecture. Thank you very much.
That was absolutely awesome, Ken. Incredible presentation. Kate, Reg,
Yes, Santi, please.
can I go?
Yeah,
Yeah.
please go ahead.
Okay, Ken, that was an awesome presentation. You lift at my ego, so I'm going to continue with that. I do have some disclosures. I do have a speaker honorarium with Intuitive, but I also love poem. As Ken just said, we've been doing this for a long time, so that's my disclosure today. We know what achalasia is, but I think that the most important thing is that affects a very small number of patients. And what I'm trying to say today is that patients with achalasia should not be treated by every gastroenterologist in the country. It should be, as Ken just said, and I think that we agree, in a multidisciplinary environment, thoracic surgery, GI, motility, interventional GI specialists, and really decide what is best for the patient. So achalasia is not a disease to be treated lightly by anyone, and I'm going to make that statement as a starting point. We know what the treatments are, and there are many. Now, let me go back to my life, because I started doing surgery in 1990, and I learned the open approach. And then I came to the US in 1995, and I learned, probably with the master of treatment of achalasia, Carlos Pellegrini, the thoracoscopic approach. And later we switched to the laparoscopic approach. And I'm going to tell you why we went to the laparoscopic approach. So the thoracoscopic approach is exactly the same approach as the POEM approach. It's a thoracoscopic approach. The POEM is thoracoscopic, starting in the chest from the inside of the lumen, but it's the same operation. No funduplication, and we see those outcomes. Then we learned robotic surgery, and in 2000, and then POEM. Now, who did this? Alfred Coucher in 93, Pellegrini in 92. I was the first one to do a robotic myotomy, and as Ken just said, we were with Marta Lamini and Gar Jacobsen, the first group to do a POEM in the US. We went to Japan. We watched many cases with Professor Inoue, who is really the master of this operation, who was an exceptional host. And we came back and we did cases. So we have been doing POEM for quite a time, and I think that that's probably the credibility of what I'm going to say today. Now, as Ken just said, this is an absolute indication for POEM. You know, a patient with achalasia after a gastric bypass. And the last thing you want to do is to go into the abdomen and be there where the bypass was. So this is probably the best indication of doing a POEM. And I think that same technique as Ken was showing, this is probably the indication. And we're seeing more and more achalasias as the bariatric surgery. So as a disclosure, this is where POEM really plays an important role. Now, the robotic HeLer myotomy is the gold standard. It doesn't matter how you do it. I think that is the way to go, and I'm going to show you why. I'm going to show you a video of a beautiful operation. We mobilize the short gastric vessels, and then we bring the robot, and we do a beautiful myotomy. Now, when you see these fibers, you can see how well you see with the robot. You have no tremor elimination. And I'm going to show you the data for robotic myotomy, and you can see how we can go into the abdomen. We don't need to think about the sling fibers as Ken does, because we're going to do a door funduplication. And I'm going to show you why we're doing the door funduplication. But you can see the beautiful myotomy there. So clearly there is a beautiful benefit. Now, our average OR time is around 45 minutes. And patients go home either the same day or the following day. So I think that there is room for all the operations. And the question is, which one is better? Or which one is for which patient? Not which one is better. And you can see there the door, and the endoscope is showing. So we do use the endoscope in a HeLer myotomy robotically, Ken, but we only use it to look inside. Now, this is the paper that Ken just showed you, where we compare robotic versus laparoscopic myotomy. This is from 2005. But Ken forgot to mention, and he was very smart, that the perforation in the robotic group is 0%. And that was very significant. So we know we have a better operation with the robot than the laparoscopic approach. Now, what happens when I don't do a funduplication? So what have we learned? Because we surgeons have been doing this for a long time. And we learned in this study from a very good friend of all of us, Saninoto, where they did 407 patients and then compared laparoscopic HeLer myotomy versus HeLer plus door. And they saw 6% only of patients develop GERD postoperatively if you do a door funduplication. So it was effective. The fascia remains very well at 5 years. So the concept that patients with a good operation done by a good surgeon in a good center do develop dysphagia is, in my view, a wrong statement. Now, this is a paper that we published when I was in Seattle with Marco Patti, Carlos Pellegrini, and Lori Way. And we compare the thoracoscopic myotomy, no funduplication, versus the laparoscopic myotomy with funduplication. And we saw excellent relief of dysphagia, but we saw 60% GERD in the POEM group, POEM meaning thoracoscopic group without a myotomy, that's what a POEM is, and only 70% in the laparoscopic group with a door funduplication. So my question to you all is, why are we reinventing the wheel? Shouldn't, for the first time, GI people learn from surgeons that maybe we were right? That we don't need to reinvent the wheel and really add a funduplication on every patient? And I'm going to value the point that Ken did of maybe adding an endoscopic funduplication if TIFF works in every patient, which we don't know up to now. Now, this is a multi-center study that we published in 2005, and this was Scott Melvin, Marta Ramini, and me, where we published 104 Nissen funduplication in robotic HeLer funduplications with 0% perforation rate, an excellent relief of dysphagia. So we learned that clearly these patients with the robot do very well. And now we have around 600 patients with very little perforation rate. My one is 1 in 400 patients, it's almost 0%. Now, what happened with POEM? And what is the reality of GERD? We know what the operation is. This is a paper from Lee Swanstrom, who really published very early, showing that has an excellent outcome. Mean myotomy length was 9 centimeters, but he demonstrated 28 and 46 shown to have esophagitis post-operatively. So really, 2 mucosectomies, 1 esophagotomy, clearly showing that these patients do develop GERD post-op. And I don't want to minimize that. Well, they don't get grade 3 or 4 esophagitis. They are continually symptomatic and they need to be treated. And we don't see that in the achalasia patient with a door funduplication. Now, what happened when we compare really POEM versus HeLer myotomy? This is a paper published not long ago in the Journal of Gastrointestinal Surgery, 140 POEM patients versus 140 laparoscopic HeLer patients out of Italy. And what you see is a higher rate of esophagitis in the POEM group compared to the laparoscopic group, 7% versus 1%, 27. Now, the median follow-up at 24 months, no mortality was seen in the group, 5 mucosal perforations, and 1 PE in the POEM group versus 3 mucosal perforations in the laparoscopic group. All perforations were repaired at the time of the operation. When we look at what happened with GERD, you can see total acid exposure of 3.5% versus 0.3%. The Mister score abnormal in the POEM group versus laparoscopic group. And esophagitis was higher with 37% in the POEM group versus only 50% in the laparoscopic group. And that's exactly the same number or almost similar to what we saw when we compare thoracoscopic group with the laparoscopic group adding a funduplication. Both operations decrease LE expression. So we don't question here that POEM is a great operation. It's an awesome operation. And I disclosed at the very beginning, I love the operation. But the POEM group was higher incidence of chronic PPI usage over the laparoscopic group. Now, if we are saying today that we are doing more funduplication because patients don't want to be on PPI, why are we going to put patients back on PPI? with the poem when we can give an operation that has similar outcomes in terms of relief of dysphagia and will decrease the usage of PPIs? That's a question for the group. Marco Patti did this study comparing 74 studies, 5,000 patients undergoing laparoscopic Heller myotomy and POEM. So that's 5,000 versus 1,900 patients. And POEM has an increase or ratio compared to laparoscopic Heller myotomy for post-operative girls. So there is no question that even though the patients stay a little bit shorter in the hospital, the girl rate is the Achilles heel, as it was the Achilles heel of the thoracoscopic approach. And that's why we surgeons stop going into the chest to do a myotomy, because patients develop a lot of GERD. This is a multi-center trial, and this was just shown by Ken, so I'm not going to go over it, but POEM was found to have a higher rate of reflux esophagitis on endoscopy at 3 months and at 2 years. Higher rate of reflux esophagitis. So again, let's think what we should be doing. And you can see here the data that Ken beautifully shown earlier. It's another paper. 1,500 cases of POEM versus 25 cases of Heller with Dorfund duplication. More GERD in the POEM group, more acid exposure in the POEM group, and more esophagitis in the POEM group, which is consistent with what we found with the thoracoscopic approach. So this is good. At least we are repeating what we learned thoracoscopically. And that's really is consistent, which makes sense. And that's why we switch to the robotic approach with the Dorfund duplication. Another study, this is coming from Lee Swanstrom, prospective single study, POEM, okay? Another study showing 3 cases who developed GERD for post-POEM, requiring now a laparoscopic approach. All patients refractory to medical treatment. So we are seeing now that we need to go back and operate on these patients because they are having very bad reflux disease. This paper, periodic endoscopy, where do we stand after a decade of poetry? So yes, POEM, and I will agree with Ken, when I compare with my previous approach of the laparoscopy, not the robotic, it has some points of better relief of symptoms, even though not significant in terms of dysphagia. But it has much more acid exposure. Patients have also commonly found to be asymptomatic with abnormal pH on endoscopy findings. And now we are seeing patients that come back to us with strictures because they were asymptomatic. And now they develop acid reflux strictures. The increased exposure on these patients of acid, much more in the POEM group compared to the laparoscopic group, is concerning also for developments of Barrett's and continued dysplasia. And here's this paper really showing now, like 10 papers, where you see reflux esophagitis up in the sky, 42%, 64%, 25%, way more than we report in the laparoscopic approach when we add a fund duplication. Try to finish. This is a very good paper from Bill Richards, and he said, okay, I don't need to do a fund duplication. Why don't we go ahead and do a laparoscopic approach only? We do a Heller only, and we don't do a DOR. And what happened? Well, if they do only a Heller, like the POEM, 47% pathology reflux. If we do a Heller and a DOR, 9.1% of pathological reflux. So no difference in surgical outcomes in terms of dysphagia. So yes, POEM is awesome for dysphagia, as it is Heller and as it is the thoracoscopic approach. But it's not good for reflux, as it happens even when we surgeons compare our own surgical patients, door or no door. This is a very important paper also to understand that we need to add the fundoplication at the time of the myotomy in a patient coming from the street which shows type 2 achalasia or type 1. Now, what are Santi's insights? There has been a rapid proliferation of POEM without a question in PIP insertions or interventional endoscopy that have no interest in achalasia. And I think that that is a wrong message. It should be treated in centers of excellence. And I think that we agree with Ken on this. POEM may often be seen as the only treatment for achalasia by these providers, and little discussion is given about GERD and complications. Again, we need to know all the data when we talk to the patients. So, unbridled enthusiasm for new procedures can make it easy to forget history, and I'm showing you the history. The history proves that if you do not do fundoplication, you get burned. And that's why we need to learn from that. Now, POEM can create more barrettes, and the question is, which patients should we treat for POEM? So in conclusion, surgeons learn from the thoracic myotomy that a longer myotomy necessarily means more reflux, but there is no free lunch. POEM has demonstrated that it's an excellent operation, but increased rates of GERD symptoms, esophagitis, and distal acid exposure when compared to laparoscopic Heller myotomy, which makes sense because I shall show you what happened to us surgeons when we don't add a door fundoplication. These findings are important to try to prevent patients from developing barrettes. Ongoing studies comparing the two procedures are in process, and I'm trying to still remain open because, as I disclosed at the very beginning, I do love the POEM operation. And I think that we agree with Ken. POEM is a great tool. It's a great technique. It's an amazing operation in a selected group of patients. POEM should not be applied broadly to the treatment of achalasia. We should not forget the lessons learned in surgery, please, when we didn't do a fundoplication. It should not be the standard of care at this time. It should not be. Myotomy and fundoplication is today the only gold standard for the treatment of achalasia until we can prove that POEM is as effective in the treatment of GERD. And to finish, I think that patients with achalasia should be managed in a multidisciplinary approach, and you should not offer only Heller, you should not only offer POEM. The patient should have access to all the operations, and it should be a decision between the physicians and the patient on which approach is better. And thank you for allowing me to present my side of the story.
Very nice, Santi and Ken, both of you. Thanks. Great presentations. Ken, any comments that you have after Santi's presentation?
What can I say? It was very convincing. I think I'll hang up my scope. Yeah, no, I agree very much with all the points made, Santi. You know, I think it really rests on the GERD issue. And I think we continue to chip away at that with an endoscopic salvage, and also minimizing the anatomy that we now are just beginning to understand GERD anatomy, really. I mean, a lot of the work done through AFS really has taught me about GERD and the importance of the sling fibers, the importance of the crura and all of that. So we're understanding that we need to continue to refine the procedure because we can very precisely navigate and avoid the sling fibers and the oblique muscles of the proximal stomach. We don't need to go that far into the stomach. You know, we measure very carefully what's going on with endoflip and with EUS. So we're getting more and more precise and intentional in terms of what needs to be excised for dysphagia and what shouldn't be touched because of potential GERD. So in our experience, well over 160 cases, we've not had one patient, and we follow these patients meticulously. Every patient after POEM will get scoped at 3 months, no matter what, whether they're on PPI or not. And we do a 96-hour pH Bravo to really make sure they're not inadvertently going to be set up for strictures down the road from GERD. So we're following them very, very carefully. We're finding that we've not had one patient need a surgical rescue. And so we feel that the POEM procedure can be safely done. And the GERD thing is something that we tell every patient. I say, look, you know, we're going to trade one thing for another. Your swallowing will get better, but you'll get GERD and you'll likely need to be on a PPI. If that is okay with you, great. Otherwise, next door, I've got Ninh Nguyen and he can do the vsHeller and Brian Smith. So we give the patient the choice, but we feel like we're making great headways in minimizing the GERD aspect, especially we can salvage those 5% with TIF.
Hey, Ken, Kevin Revis had a comment that in the Portland group, they had been using the bunny trail approach and it had a number of mucosal defects that required closure with clips. And so they had sort of abandoned that technique. You and Kevin, I'm sure, have talked about this, but do you have any comments on that potential risk and what you've done to avoid it?
Yeah, I've done, I think, over 50 with the navigational pocket and no issue at all. I've not had to take one clip out. So I use a 25 gauge needle. It's a tiny needle and it's not, you can't see them afterwards. So we're not finding the need to, you know, close the little needle puncture sites.
There is a question by Rina, if I can reply that, Jen.
Yeah.
Right? So Rina is asking if maybe, first he's congratulating you and me, Ken, and then she's asking if POEM should be the operation of choice for type 3 achalasias, and I cannot agree more. Because I think that in those patients, I prefer to wait to see if they need a door fundoplication later and really do a long myotomy, because those patients otherwise, right now we are doing abdomen and chest, and going to the chest is not benign. The lung is stuck to the mucosa, etc. So I think that we have the first type 3 myotomy at UCSD, I think that next week. And probably, I think that we agree. These two lectures agree on a lot. And the message is, it should be done by a multidisciplinary approach where you can offer both operations. But there are clear indications for POEM. Reduce, bariatric patients should not be treated with a myotomy. I got burned by doing sleeves with myotomies, and we learn, and now we do POEM. So it's not everything. You know, it's a balance. Which patient you treat with PPIs and which one you do an Nissen fundoplication. If you do all Nissen fundoplication, there is a problem. If you do all PPIs, there is a problem. And I think that the same is happening here. And as you said, you know, Ravi Mittal at UCSD is a big fan of the sling fibers. So we are all embedded into sling fibers here. and I think that there's a lot that we are learning from that and the hiatus. And the more we do this under strict protocols and working together, sharing data, this is what the AFS brings to the table, that we are going to share all the data and find the best operation for the best patients. And I think that there are clear now indications for POEM, and that's the beauty, I think. That, okay, what should be a POEM? What should not be POEM, and what is in the middle that will go one way or the other? And probably that's what we will define in the future. Make sense?
Agreed.
So, yeah, very good comment, Santi. And I think not only are we moving towards sort of personalized and individualized care, but also I think we're recognizing that that procedural interventions are indeed proceduralist specific. If you look at the wide range of pH abnormality, reflux after either of these procedures, it tells us that expertise is key to good results. And sometimes the best result is, as we used to say about hernia repairs, the best result is the hernia repair you know the best. And so, and with that in mind, it seems to me like Werner's paper in the New England Journal seemed to have a very low incidence of objective reflux in the POEM group and a pretty high incidence of both complications and reflux in the Heller-Dorr group, compared to many of the studies that Santi showed, which were also comparative, although not randomized in the same fashion. Do you have any comments, either of you, on that? Sometimes we take an RCT and we hold it up as the definitive endpoint, but when it isn't exactly in line with all the other studies, you have to kind of ask what's going on there. So, any comments on that?
Yeah, I mean, a couple of comments, because I also, read all the fine print in the paper, and one interesting thing was that their poem proceduralists, they were pretty inexperienced. The requirement was 10 cases, and they actually had a pre-trial roll-in where the physicians were taught how to do poem, and they had to have done 10 cases before they can enter into the trial. So to me, that's really early, whereas the laparoscopic surgeons had been doing Heller for many, many years. So that was an interesting piece, that these were pretty novice poem proceduralists. The overall outcome was low, I think, low-ish in both groups, which the authors did acknowledge. So you're right. It is. We look for these randomized studies, but there's great operator variability. I've watched many people do poems. I myself was taught by surgeons. Steve DeMeester was part of that learning curve for me. I got ingrained with a lot of the surgical principles very early on, but I've seen some very cowboy poems done in. There's some bragging rights that, oh, I can do a poem in 15 minutes and so on. And yeah, so there is variability in terms of who's doing it.
Yes, Ken, that's a very good point, because we don't have every surgeon doing myotomies or achalasia. They just don't. I mean, here in San Diego, I get most of the referrals. Ning gets all of them there at UC Irvine. There's one or two surgeons doing them, and we don't have everybody doing myotomies. Everybody that do gallbladders, but not myotomies. And I think that with POEM, we need to go to the same concept, that it should be an operation done by people who have expertise, who do motility, not because they think that they can do more RVUs now with a surgical approach. And I think that that's probably the message here. And I think that the message is POEM is a great operation, and we need to find the indications, and we need to find, I would love to find how we can stop acid reflux, because it's a cool operation, as you were saying. We did very early, and we put cool everywhere, and I think that it has a lot of indications. And I also love to do the robotic myotomy, but I think that if we can find a compromise in terms of GER, then POEM wins, because it's less invasive. We learn a lot about opening the esophagus, operating on the third space. We are not scared about that anymore, and we need to find the right operation. And I think that doing endo flip at the same time is going to teach us a lot. Maybe don't do so much of a POEM, because POEM is overly good in terms of relieving dysphagia, and maybe it's too much, right?
I absolutely believe. I have been, for 7-8 years backing off on my myotomy incrementally, millimeter by millimeter. I've been doing less actually over the years. And I find that I haven't compromised the dysphagia, but the GERD continues to improve.
And
I'm a little bit on the far end of the spectrum in terms of my anal retentiveness. So for every poem, I'll do the endoscopy, I'll do endoflip prior, I'll do an EUS prior, map out where the vessels are, know exactly how thick the muscle is, examine the crura, see how intact the crura is, measure the LES. So I go a little bit overboard, and then I'll do the poem, and afterwards I'll repeat the endoflip. And if I don't like the endoflip, I'll go back in. So quite a bit there. And so I agree that, we need to continue to refine this. One question I had for you, Santi and Reg and the group is, we can, and we've done a handful of poem plus TIF in the same patient. And that is your surgical paradigm for lap Heller plus door. It's very doable, not risky, and same concept. We just shift the TIF so that the myotomy becomes our lesser curve, or our 12 o'clock, where we're plicating towards the myotomy as opposed to over it, which may help the myotomy to stay open. And there is some aspect in type 1s of being able to increase the intra-abdominal length of the esophagus and straighten the esophagus a bit in the thorax. So I wanted to, we're not doing a lot of these. I'm still, cautious, but what are your thoughts about that paradigm?
And Reg?
That's a really interesting thought, Ken. And I think, again, it depends a little bit on exactly the orientation that you're talking about. Not only probably not so much in terms of closing down the myotomy, but in terms of the potential for a leak if you're going and placing fasteners through the myotomized segment of the esophagus. But I think it remains to be seen. I mean, we know that globally the pH control with TIFs is not as good as with a door, but it may be adequate. And I think, just to go back to that, one of the questions that I've had is that it seems like the reflux rate for POEM is less than with a Heller without a fundo. And I've wondered if maybe that's because we're not dividing all that adventitial tissue.
Absolutely.
And some of the longitudinal muscle fibers. And so if that's the case, then a TIF may be a very good operation on top of a POEM. I think it remains to be seen. We need some more longer term information on that, but I think it's a very, very viable thing to think about.
I think that I mentioned that during my presentation, that I think that I'm not a fan of TIF for a de novo GERD patient, but I think that we try not to give patient dysphagia. That's why we don't do fundoplication Nissens or links or in a myotomy. And I think that TIF is not as effective as a 270-degree toupee, but it can be enough to do the door that we need on these patients. And I think that maybe at the same time, or maybe on the patient that need it later, we do TIF. And we monitor those patients. We don't need to do it on the same time. Maybe we can do it later, but maybe there's going to be a huge role of TIF in these patients. And I do agree absolutely 100% with what you both are saying.
Yeah, so we're now doing this staged approach, and literally on the day of the consultation, when the patient walks in the door and we talk about POEM, I also I tell them about TIF, and I said, 5% chance that you might wind up with a TIF. So I plant that seed up front and follow them carefully, and if they need it, they need it, and they're not surprised. Those who obviously may benefit from same time will do that, but these are just a handful. Yeah. So I think this to me makes sense.
We're about out of time, but Raina had a question about the preferred method for gauging the length of the proximal myotomy. And I'll add into that, Ken, since you've said you've done your myotomies shorter and shorter on the distal extent, how have you been gauging that? So if someone's looking at saying, what's the expert doing? How do they know where to go that way?
I can tell you what we are doing at UCSD, which is like Ken, every patient with achalasia gets a EUS, all of them. And then we know, even when we do robotically or up to where we need to divide the muscles. And I think that that's important, because if you only have 2 or 3 centimeters, you don't need to do a 10 centimeter myotomy on that patient. Neither the point, neither the robotic. You need to go short and do a short myotomy. And I think that EUS is going to become the new standard of care for these patients, because you can really map that esophagus. I mean, we have patients that we only say, we need to just only divide the valve because the muscle is 1 millimeter in thickness, and you need to do a 10 centimeter myotomy for just to open the valve, right? And do you agree with that, Kim?
I agree completely. The very tailored, individual, personalized approach. For the proximal esophagus, I tell you, all these patients get endoscopy, they get a time barium swallow, they get manometry, and they get endoflip, and they get EUS. And any or all of those will inform me how high I need to do the myotomy, because it's in every patient it's different. In some patients, if you follow the thickness of the muscularis propria all the way up, there can be an obvious transition point. So that's an indicator. Also, during EUS, we can actually see spasm happening, and the EUS balloon will deform when the muscle wraps around it and spazzes during the middle of a case. The endoflip can also help. The manometry can also help. And the time barium, like I showed you in that slide, you can see the spasm. But in every patient, it could be 1 or 2 of the modalities show spasm and the other may not. I'll just go with the worst case, and I'll do the myotomy based on any of the worst case from any of the above. A lot of times, just on endoscopy, before starting, I'll sit there and watch for 2 or 3 minutes and see where the spasm is, and then I'll plan my myotomy based on that. So that's on the proximal side. On the distal side, when I started, it was the surgical dictum. You must cut 3 centimeters into the stomach. So I did that, lots of GERD. And over time, I inched back 2.5 centimeters, 2 centimeters. So the way, and I used to confirm distal extent of the tunnel just by injecting a bunch of saline and going into the stomach and retroflexing and looking for the bleb. That's very imprecise. So what we've done in the last 75, 80 cases is we, while the gastroscope is in the tunnel, we put a 6 millimeter baby scope alongside, go in the stomach, retroflex, turn off the light, turn on the X-lume on the scope, and we can actually see the light at the tip of the scope at the G junction. We want to go 1/2 to 1 centimeter below the LES and not more. We don't need to cut 3 centimeters of sling fibers for what? Not necessary. So once we've confirmed we're far enough, we stop. And that has really helped in terms of minimizing GERD.
I think that something I like a lot about these lectures is what can I learn, and a lot of us surgeons are in love with your scissors knife technique. So Kevin Revis is also asking, which one is that? Because I want to use that too. So which scissors are you using?
This is called the SB knife, which is named after a Japanese beetle. But it's an Olympus SB knife. There are 3 sizes. There's a regular size, a medium size, and a junior. So I use this for Z poem as well as poem. It's
and that one is scissors?
Yeah.
It's beautiful.
Yeah.
It's gorgeous.
Yeah.
Okay.
I mean, the last thing you want to do with a naked knife is inadvertently, you know.
Tell me about it. We all did it.
Okay, well, we'll wrap it up here. Really great discussion. And just to let those of you who are still here, which is actually all of you who signed in early, as we look towards our virtual meeting, September 25th and 26th, we're really going to focus on the how I do it stuff. So the nuts and bolts of foregut. And so I think you'll hear a little bit more about the techniques that Ken and Santi have been using, along with other techniques with some live cases and some other discussions. So stay tuned for more information on that. We're finalizing the agenda now, but we'd really love to see all of you there. With that, we'll sign off and wish all of you a great weekend.
And awesome job. Thank you, guys.
Thank you. Thanks, Santi. Bye, Reg. See you,
Bye-bye,
Kate.
Ken.
Bye, Reg.
Bye, Santi.
Bye, Kate. Thank you.